Hi, this is Glenda Beasley, and I am a RAC certified RN through ANAC, and this presentation is regarding one component of our PDPM reimbursement system. It's called the heartbeat of your facility. As we all know, most of our revenue is driven through this process now. So I felt like it was important for us to examine a couple of the components of this and to answer questions and to provide the administrators with some potential questions that they could ask during their weekly Medicare meetings to help drive some conversation and ensure that you're achieving the most appropriate reimbursement for your facility through this process. So our objectives today are to look at some questions that would help to simulate the IDT into a deeper look into the reimbursement issues during your weekly Medicare meeting. And hopefully administrators are attending these meetings to really ensure that they're staying on track and meeting the objectives of the facility. Ensure your facility is capturing the most appropriate PDPM reimbursement rates. And as I said, we're going to be reviewing the one component, which is your NTAs. Also, we want to look at eventually, should nursing skill continue after therapy has been completed? And what questions and care issues should the administrator be reviewing or discussing with the IDT to bring that information forward and ensure that the residents' care plan, discharge goals are all being geared towards a successful discharge plan. Additionally, reviewing secondary payers before the 20th day. This could bring about some conversation with, has the Medicaid application been looked at, completed? Has the family or resident discussed their willingness to proceed in that application process? And if not, what are the barriers? And lastly, what is the secondary payer going to be as of the 21st day? And last objective is to talk a little bit about benefit exhaust. And is that the right call for the residents? There are some clinical issues where benefit exhaust would be the objective for the stay, as once the resident exhausts those benefits, they would not be eligible to initiate a new 100 days due to their ongoing need for skilled care. So NTAs, the non-therapy ancillary points. What should the administrator know and what questions to ask to drive the discussion during the Medicare meeting? So NTAs are identified under the PDPM as one of the 6 components that drives the overall PDPM rate. There are 50 conditions that are related to increases in NTA due to the increased cost to the SNF. These conditions are categories, and we will look at those a little deeper in a moment. Total number of comorbidities are linked to NTA cost. So a resident with PD and diabetes, we would be looking at picking up 4 NTA points there. So the combination of the comorbidities are linked to increased cost. So Medicare has given us the opportunity to capture the reimbursement according to the cost for the facility. The comorbidity scores are weighted, therefore some of the diagnoses that are used to establish the NTAs have a higher point score, and these are not all just diagnosis, but can also be actual clinical indicators, such as a resident that is receiving IV therapy during their stay at the facility that would score higher at 5 points. So it's important that we're capturing all of those points during that look back period. Points assigned to each additional comorbidity, we would award more points due to it ending up the resident's care is at a higher cost tier, and extensive services and isolation being at one of the top areas for nursing in the nursing categories. So NTA point types of questions that the administrator could ask is, how many points were calculated for this resident and what are they for? Is the resident on any IV medications at the facility, and was this coded and captured in section O as the IV medications, as we said before, is worth 5 NTA points? Was malnutrition or the risk for captured encoded in section I, along with morbid obesity? If they have morbid obesity, do they have the appropriate diagnosis code, and was this captured and coded to section I? Infections, MDROs such as VRE, MRSA, ESBL, is a diagnosis code inputted for these, and were these coded into section I? This increases your NTA points having these MDROs by 1 point. For diabetic residents, do they have a foot ulcer? This is coded in section M, and does the diagnosis also exist, and was it coded in section I? This diabetes captures 2 points NTAs, and with the addition of a foot ulcer, there would be a total of 3 NTA points awarded for that diagnosis. This is one of the original CMS category forms for NTA points, and I think that a lot of times people look at this as this list being inclusive, and this is really just categories. There are hundreds of other diagnoses that are related to NTA points. Some of those would be underneath a malfunctioning device for a patient, malfunctioning G-tube, malfunctioning Foley catheter, any type of device associated with the patient. It's worthwhile to look at those potential diagnoses that would be relevant and ensure that you're capturing those. So just remember, this is a broad these are categories, and underneath these are multiple hundreds of diagnoses that could increase your NTA points. So NTA rates are set annually by CMS, and they all vary based on state, county, and rural versus urban. The example here is from Medicare fiscal year 2023 for Wayne County, Michigan. And as you can see, the NTAs are broken down by through NF being the lowest category, where there are 0 points awarded, but the daily rate that's associated with that category would still remain at $55.73. For the points as you go up in the grid would be, in our first example of having a patient with diabetes and COPD, we would get 4 NTA points. That would put you at a ND level, which requires 3 to 5 points, and that would increase the rate from the set $55.73 a day to $102.70. So almost a $50 a day increase for capturing those appropriate diagnosis codes. So as we said earlier, PDPM is the case mix is driven by a number of components. Today's focus is on the NTA points. There is also a nursing component, a speech language pathology component, PT and OT, which are a combined total rate, but each one is individual. And then there's a non-case mix, which is a rate set by the federal government, which does not have any parameters that you have to qualify for. That's just set. That case mix rate does vary from state to state, county. So taking and adding all of those qualified components together would equal the resident's daily rate for you. This is a look at what the rates look like for Wayne County for fiscal year 2023, those rates became effective on 10/1 of 22 through 9/30 of 23. And this is just to give you an example of what the rates look like. So if you're looking at a resident with a very common TK PTOT rate, your daily rate would be 174.10. Looking at and you can go across and find the various differences in your rates, which allows the administrator to know when they're speaking with the staff what happens, what rate is a good rate. Many times you'll see that the HIPS code for nursing might equal an X, and in that case, your rate would be the PBC 1 and $116 a day. Very low rate. Really want to take a look at the residents that are falling into these low-level physical reduced categories to ensure that you're capturing all of the appropriate documentation for that patient. One other thing regarding NTA points is there is a VPDA variable rate that is increased by 300%. So day 1, 2, and 3 of the stay, that ND rate that we were talking about, the $102 a day, would be multiplied times 300%. So it would be 306 approximately per day for each day 1, 2, and 3. And then on day 4, that rate drops back to the baseline rate of 102.70. That rate remains consistent throughout the stay. That does not change. The only rates that have a mandatory change is the PTOT combination rate, where as of day 21, those rates start to be reduced by 2% every 7 days throughout the stay and up to the end of the benefit period, which would be the 100 days. So every 7 days after day 20, you would experience a 2% decrease in that rate. So HIPS codes, how do an administrator take a look at and identify the NTA component we're talking about? So the NTA is always the 4th letter of the HIPS code. So in the gray box, you can see this example is NB. So if I had a HIPS code of LBAB1, the B in the 4th spot would equal my NTA point level. And then you could use the prior grid to see where your potential rate falls into that category and how many points it took to get there. Your MDS coordinator should be able to speak on what NTA points and or other categories were included in combining to get to that NB level, which would be something that you should really discuss during your meetings with the team, as that NB would require 9 to 11 NTA points to get into. And it's worthwhile to take a look at and make sure that you've captured everything, and be cautious of using an IPA for a change. If it's going to drop you down and you're going to lose part of those points, let's say an IV therapy has been discontinued, but the resident has a new diagnosis or went out and came back, and you're eligible to use an IPA assessment. So make sure that you're looking at how those rates change if you're going to use an IPA assessment. And finally, questions for the administrator asked during the Medicare meeting. So your Medicare benefit days, have they been verified? And that would be something that the BOM should be able to speak to. Your benefit exhaust date. Does the MDS coordinator, are they aware of when the benefit exhaust date is? Will the resident be continuing as a long-term care, or will they be discharging to home or another facility? And what is the payer? So after Medicare ends, if they're going to become long-term care. We should also be discussing the secondary payer. Has the copay benefit been validated? This should be done in the first 20 days. You'd like to have that information right away. If there's no secondary payer, what financial arrangements has the facility business office made to ensure that the co-payment amount is being paid, so you're not chasing those funds afterwards. Again, has a Medicaid application? Has it been started, completed, barriers, family doesn't want to do it? So this should be incorporated into part of your Medicare meeting. What was the primary diagnosis for the resident? Are the care needs being addressed? Consults made, referrals, and also education by the nursing staff. Is that being conducted with the family and resident in preparation for discharge? Your skilled documentation is what is the ongoing skill. So if that should be driven from your primary diagnosis, and is there daily documentation, and that includes more than just a skilled daily note. Notes could be very benign, so that takes into account your therapy progress notes, your MARS, your TARS, your physician documentation, consults, referrals. There's many places the documentation comes from that supports the skilled need. Were the BIMS and PHQ-9 assessments completed by the ARD? And if not, were dashes used to complete these? Your social services should be able to discuss if they've used dashes at all to complete their assessments, as this does start to add up and can bring about an increased number of dashes, could affect your QRP and put the facility at risk for a further 2% reduction of your Medicare revenue. So you'd like to make sure you're completing those assessments and avoiding the use of dashes if possible. What is the discharge plan? And we should start talking very early on as to what is the tentative discharge date, so that care plans can be updated, families can be given tentative discharge information, social services or your discharge staff can look at what needs does the resident have, setting up services, looking at all of those issues, and to ensure that your nursing department is providing real-time education with the families. NTA points for the resident. You should be asking that question during the meeting. Any patient with a 0 NTA points, while you still have that base rate of $55 based on the example we have here, that should be an automatic review to ensure that the referral and all relevant H&P and consults were reviewed to establish if there should have been any NTAs coded for this resident. So I would, if as an administrator, would be asking if that review was completed. And then outside appointments. So under Medicare, in the building, you're responsible to maintain all the expenses that go along with the care of the resident. So one thing that happens frequently is, since the resident's in your facility, the families start to try to move appointments, and mom has this ophthalmology appointment. It has nothing to do with their stay, but they want to get that done while they're at your building. You should have some policy regarding the scheduling and the facility's responsibility to provide services and transportation to those appointments that are non-related to their current stay, as that is an additional expense for the facility. I think if you start asking a couple of the questions, and if you've not been attending your Medicare meeting, then at least having this last page of having some questions to be able to ask your staff, engage with them to find out their understanding and to look for opportunities for reviews and provide additional education is a very important goal for the administrator. And here at SMK Medical, we are available to consult with you and to help provide additional education to bring your facility up to a level of billing for all appropriate reimbursements for your resident stays.
So we'd like to thank you for attending today's presentation from SMK Medical. If you have any additional questions on how SMK Medical can assist your long-term care facility, you can visit our website at smkmed.com or call us directly at